So our first session is delivered by Andy Menzies-Gow. So I first worked with Andy many years ago, and he was a respiratory, he probably remembers, he's laughing, a respiratory registrar at Worthing Hospital, and it was a lot of fun. And I've enjoyed watching your career develop over the years, Andy, and it's a really great pleasure to now be introducing you as National Clinical Lead for Respiratory Diseases. So Andy's going to give us an update and an overview of the National Respiratory Programme within the context of the COVID pandemic. So I'm going to hand over to you, Andy, and then we'll come back until you're okay to have a few questions at the end.
Thanks, Jo. I will now try and share my screen. Hopefully that will work. It's an absolute pleasure to be on this call. It's, as always, a great shame that we're not here together in person, but hopefully at some point we'll get there. Now, can you see my screen, Jo?
Andy, we can see the slide, thanks.
Perfect. Okay, great. So about half an hour with me talking and 15 minutes Q&A, and we'll see how we go with that. So very clear title, and I'm going to cover three aspects. Just to remind everyone where we were back in January, because the world has really spun on its axis and many things have changed and will continue to do so, but we need to not forget the priorities that were incredibly important before COVID hit us. A bit of time reflecting on the impact of COVID on our patients and the delivery of respiratory services, and then restoration and recovery. So how we continue to deliver through what is starting to be the second wave and until we get past endemic COVID, and hopefully not too much overlap with Mark's talk later on. Take us back. This is the screenshot from last year's respiratory ambitions within the long-term plan, and a really important moment for respiratory medicine. Clearly recognised that it's an area where the NHS hasn't focused as much as it could have done in the past, but does want to moving forward. So a huge impact of 9.9 billion a year, 1 in 5 people affected by respiratory disease, the third highest cause of mortality. And importantly, unlike some other areas, hospital admissions for lung disease are continuing to rise over the last 7 years, and a significant factor in winter pressures, which I'll come back to and talk to you a bit later on. So a very ambitious 10-year plan to transform the way that we deliver respiratory care. And I think also importantly, and even more so with COVID, really embedding at that point the understanding that health inequalities pay a huge impact in respiratory medicine, and that we need to do better in terms of treating people from all sorts of different communities and backgrounds who don't access care in the way that we would want them to. So back at the beginning of this year, we had several work streams that we were really prioritising. We really wanted to focus on early and accurate diagnosis. So that's around getting quality assured spirometry for everyone, measuring airways and inflammation earlier, and setting up, for want of a better word, diagnostic hubs at the primary care network level. I'm a really passionate believer in early and accurate diagnosis, and it's not good enough, and I'm sure no one on the call does this, but if you are breathless, going to primary, secondary, even tertiary care and getting a label of a disease without the right objective tests up front doesn't do anyone any favours, doesn't necessarily treat the underlying condition. There's a big issue about medicines optimization, which I'll come back to, and it really isn't good enough. And you know, for many years I've stood up and said, well, our cardiac colleagues wouldn't accept making a diagnosis of heart failure without at least a BNP and echocardiogram, and then further investigations to think about the cause, and we should really be driving and striving for the same for our patients. The next thing was around increasing access and maximising the uptake for pulmonary rehabilitation. It is such a clinically and cost-effective intervention that we recognise we need to do it more and we need to do it better. And again, I know that later on you've got Julia and Sally talking about how to do that at the current time. Medicines optimisation, we spend a significant amount of money, particularly around inhaled therapies, with approximately £1 billion spent on asthma therapies. And we recognise that often people are taking short-acting beta agonists without any inhaled corticosteroids. We recognise that many people are taking huge amounts of short-acting beta agonists really poorly. Thank you. And I think most importantly, we recognise that unlike in other conditions, it's really hard to take inhalers correctly. It's very easy for most people to take a tablet. It's really hard to take an inhaler correctly. And as many of you know, I work at the Brompton, and if I asked all my professorial colleagues to demonstrate inhaler technique, I can almost guarantee to a person that they would all struggle to do it correctly. So an area that we do really need to improve. Community-acquired pneumonia has been one of those areas that really hasn't been focused on, and we were all set up with a really great sequence we were going to do at the front door in A&E to improve outcomes with regards to community-acquired pneumonia. Breathlessness is a key symptom, and I think we've now got to the point that actually we understand we're going to do early and accurate diagnosis for breathlessness across the piece, working really well with our cardiac colleagues up front. But for many people, breathlessness remains a disabling symptom despite our best interventions, so we need to do better and help people cope with this difficult symptom better. Finally, flexible learning. So the concept of this is really around when you're given a label of asthma or COPD or another chronic respiratory condition, how much can you take in day one? How much can you embark on shared decision making? What sort of information do you want straight away? What sort of information do you want over the next few weeks to months? And flexible learning has really come to the fore as we've moved from face-to-face towards virtual consultations. And then just to remind everyone, it isn't just about the general respiratory conditions. So we also look after specialised commissioned respiratory services. So these are, you can see the list here, but essentially it's severe asthma, interstitial lung disease, cystic fibrosis, pulmonary hypertension, and then complex home ventilation and weaning patients as well. And that's probably about 10% of what we do. So the majority of respiratory medicine, as we all know, happens in primary care, with some into secondary care, with a small minority, but important minority, taking place in specialist clinics. So just to reiterate Joe's comments, and I say this to everyone in NHS England and Improvement all the time, respiratory medicine as a specialty across all the professions has had such a challenging year. I really remember those dark days back in February and March when we were really at the forefront of what felt like a tsunami wave at that point. We had to pause routine activity earlier than other areas. We had to really be on the front line. And as Joe said, dealing with a once-in-a-century pandemic should not be underestimated. I can completely remember the first time we were looking after COVID patients, and we hadn't seen it before. We didn't know what it was going to do. We didn't know who it was going to affect. And now we're left in a scenario where the majority of patients admitted to hospital are certainly being followed up by respiratory teams. And to give you an idea, in a big London teaching hospital, that might be 1,500 to 2,000 patients that were admitted, another 500 patients plus that went through the A&E department, all who need follow-up in a relatively short order to make sure that they're improving. And our best guess, approximately 10% might end up with long-term pulmonary fibrosis as a consequence. Lots of other symptoms, and lots of stuff now coming out about people who didn't actually go into hospital but are very symptomatic, how we best manage those. And this is at a point where we have all of our catch-up to do in terms of everything that we were meant to be doing and that we paused to cope with the initial surge. The fact that respiratory medicine is often at the front of the current COVID admissions as we seem to be going into a second wave. A huge, quite right focus around critical care, but that's only for about 20% of COVID patients. About 80% were in general and acute beds and often managed by a respiratory team. So almost a quadruple hit in that respiratory services are looking after the next surge of COVID patients. We're having to follow up the first wave of COVID survivors. We're trying to pick up everything that we were doing pre. And then obviously because of where we are now, we're coming into winter, and everything that we wanted to do around early and accurate diagnosis, medicines optimization, pulmonary rehab had to be paused. So there's a potential for the winter bed pressures around respiratory medicine to be even more acute than they normally are. But if we think about what we've learned from COVID, it's a huge amount. So this is back to something that happened relatively early on around shielding. So we presumed that everyone with a respiratory condition would be at increased risk with this respiratory virus. And you can see it's been updated since, but the guidance is the same from PHE and the Chief Medical Officer's team, that clinically extremely vulnerable people should shield, and they did shield for a prolonged period of time. That included many chronic respiratory conditions, including severe asthma, cystic fibrosis, and severe COPD. And I think it's only now that we're really understanding the impact of shielding. And I'll show you some data to suggest that it does protect against common respiratory conditions, but it has such a significant psychological impact that we really need to think how we manage this population and at-risk populations moving forward. So I think it's really difficult to know the impact of respiratory conditions on COVID. And certainly at the start, we were looking at evidence coming out of China, evidence coming out of Italy, Spain, France that was contradictory and not necessarily that complete. A lot of people will quote the Open Safety study. This is now being published, saying that respiratory diseases increases your risk. I think this is relative rather than absolute risk by 1.78, and asthma by 1.11, with steroid use by 1.25. And that was, I think, to my mind, incorrectly interpreted that people with severe asthma were increased risk. Actually, I would suggest that this indicates that people with poorly controlled asthma were at increased risk. And it's not yet published, so this is a personal communication. When we've looked across our UK severe asthma registry, actually being on a biologic doesn't increase your risk. Being on oral or high dose inhaled corticosteroids, again, do not increase your risk associated with COVID. And those similar sort of figures have come out of Italy and other centres as well. And if we look at the risk around respiratory conditions, 1.25 to 1.78, it's dwarfed by the other more conventional risk factors. So, for instance, age still remains the biggest single risk factor, with depending on how old you are, you're risking up by 12.64 times. So respiratory conditions are important, but possibly not as important as we thought they were. And indeed, certainly in asthmatics with COVID, we're not seeing bronchospasm. We're not seeing that standard presentation we would with other viruses. They present in exactly the same way as people without asthma in terms of getting the COVID pneumonitis. In terms of the different services, really important that we managed to continue all specialised respiratory services during the first surge. Had regular meetings between the CRG leads and our wider specialist communities. And I would say that the respiratory community per se is pulled together in a way which was just remarkable to see. I never picked up the phone and someone said, I'm too busy to help. They said, Andy, what can we do? Every time it was just an amazing pulling together of everyone to work with a single purpose, which I think we will hopefully continue to pull forward. We produced some rapid guidelines, and I'm going to just share one around severe asthma, which is one of my passions, just to demonstrate how quickly we move the field forward. The British Thoracic Society have been absolutely fantastic during all of this. I've had regular collaborations with the executive, who've produced guidelines at very quick pace, been incredibly helpful, incredibly supportive to the whole community, as has the Primary Care Respiratory Society, the Royal Colleges, etc. And we work closely with our patient-facing charities to make sure we get the right messages to people, because I think it is worth remembering how terrified our patients have been and continue to be in the wake of this pandemic. So just to give you an example of one of the things that changed at pace, so this is the COVID-19 rapid guideline for severe asthma. And to give you an example of the difference between this and the standard NICE guideline, now I chaired the original NICE guideline for asthma diagnosis and monitoring. That took 18 months. We wrote the COVID-19 guideline in a weekend. I'm not sure which of the two methodologies I preferred, probably somewhere in the middle, but it just gives you an idea of the pace that we were working under. And the idea of this and all the other guidelines we produced was really to do the right things during the pandemic. So what to carry on doing, what to stop. And clearly, the first thing that we said was to minimize face-to-face contact, moving to video consultation wherever possible, using technology wherever possible, using all the volunteer networks that became available. I think for respiratory medicine, and this is well recognized now, one of the problems we have is we're very reliant on pulmonary function tests. We're pretty reliant on bronchoscopy in certain areas. And these are potentially high-risk aerosol generating procedures. So how do you manage to do these when people might have COVID and 75% of patients with COVID are asymptomatic? It becomes difficult. And initially, the ARTP and the BTS put out this guidance saying that all pulmonary function testing was a high-risk aerosol generating procedure. Now, full disclosure, this is not entirely aligned with the Public Health England guidance, and this has caused some issues. This was very much there's a lack of evidence, so we're going to go for the very low risk approach. And while I can understand how this was relevant at the height of the initial pandemic surge, it soon became obvious that we needed to take into account the risk of not doing these diagnostic tests in individuals, as well as the risk around COVID. So after lots of discussion with the ARTP, we've moved forward quite significantly, and this is taken from their updated guidance, where you can take a much more pragmatic view, looking at the procedure, whether it's a high flow or a low flow procedure, for risk, the patient, whether actually they've got COVID, whether they've been pre-screened, or whether they're on a COVID protected pathway. In terms of negative pressure rooms, your rate of changes, whether or not you've got air scrubbers, etc. So you can come up with a much more pragmatic, sensible local guidance. Now, I recognise this works really well in secondary care and isn't so helpful for primary care, but it's certainly a step change forward and has allowed us to significantly increase pulmonary function tests. At one point, we were down to about 30% pulmonary function testing capacity in our trust, and we're back up to about 60 to 70% now using this guideline. So a significant step in the right direction. Bronchoscopy has also proved a challenge. It clearly is a high-risk aerosol generating procedure, and endoscopy suites just don't do bronchoscopy. Clearly, there's upper and lower GI endoscopy as well to do. I think all the endoscopy services are now stood back up again, and certainly those procedures that need to be done around malignancy and others, which will cause a significant and immediate change in treatment, and now or should now be being delivered in a timely fashion. With regards to the high-cost therapies that we use, we've really seen a step change. So we used to bring everyone up to our trust, and many of you from KSS, patients would be coming up to our trust up at the Brompton, and they'd be travelling a couple of hours each way to every 2 weeks or every 4 weeks or 8 weeks, depending on the treatment they're on. And we flipped that on its head. In 2 weeks, we took 550 patients and switched them all to home administration. Now, we probably would have done this anyway over a period of time, but it would have taken us 12 to 18 months, and we did it in a fortnight. So this is one of the positives that we've seen out of this. And we've absolutely moved to remote treatment and treatment from home wherever possible, and we won't be moving back. Also, we just relaxed everything a bit around how to measure adherence and how to be a bit more pragmatic, and we went from the whole MDT to just 2 senior clinicians, because we recognize that biologics are transformative for severe asthma, and we didn't want to pause them in the middle of the COVID pandemic, because we felt, and I think the evidence suggests that we were correct, that being on a biologic will actually protect you more than not being on it in terms of your risk of COVID and your risk of severe and life-threatening asthma. We did all the boring things around blue tech forms to allow this to occur. And we worked very carefully with the home care companies to make sure that this could happen. So very similar changes, and I'm going to show you some of the stuff that's happening in CF in a minute. We did similar things around interstitial lung disease and pulmonary hypertension. This is just to say that I think really importantly, I still get some patients. It's interesting at the start of the pandemic, it appears that people picked up a lot of their prescriptions for their inhaled steroids. Some people stopped their oral corticosteroids because they're worried about COVID. Others doubled their oral corticosteroids, but we've got some clear guidance that you should stay on what you're on, because it's much better to have your asthma or your COPD or whatever it is well controlled, and then we treat the COVID on top. So I use severe asthma as an example, but in terms of the paradigm shift that we've seen, we won't be going back to where we were for lots of reasons. I mean, I think care close to home has to be the default. And certainly my standard severe asthma clinic now is done over the Attend Anywhere platform, and it works incredibly well. People, for instance, don't have to come up from Worthing on the train to Victoria and then get a cab across to South Kensington. They can be at home having a coffee. I dial into them, they see me, that's fine. They can show me their inhalers. We can do inhaler technique over video. We can do peak flow very easily. And we've also invested in handheld spirometers for patients that need them. So again, that they can measure the objective measurements closer to home. Certainly the vast majority, I would say 95%, like to give their biologics themselves at home. The majority of the biologics come in auto-injectors, incredibly easy to use. We still attend a consultation with our nurses on the day of the biologic injection. And when Asthma UK have surveyed people with severe asthma, they're delighted to give the drugs at home. Their big worry was that the centres would spend less time with them. They wouldn't have those close links. And we've got around that by using Attend Anywhere. The only time Attend Anywhere doesn't work, and I'm sure we all have seen this, is when patients are acutely unwell, because clearly it's very hard to do that much over a video consultation if someone says they've got chest pain or they're more breathless. You can do some things, but you can't do everything. So in combination with that, we've set up a ambulatory care units to counter that. But I think for the majority of respiratory follow-ups for chronic conditions, moving to virtual is certainly the way forward, and certainly was always within our long-term plan ambitions. We've just significantly moved the time frame forward. And then sort of for the second half of my talk, sort of understanding the impact of COVID, I think is key. This graph is often used within the NHS. You can see the red first wave that clearly we're through, the green second wave that we're in, at the same time as trying to catch up with conditions and management that was paused, the follow-up for patients with COVID as well. And then I think really importantly to focus on the fourth wave, the green, and this is the PTSD and depression, and not just for patients, but for staff as well, and staff burnout. I think hopefully many of us have had a chance to have a holiday, which at least will physically recharge us, but I think it's important that we all understand where we are psychologically. And talking to my teams over the last few weeks about getting ready for the next surge, it's hard to get everyone up again and get ready to go again. And I think it's really important that we support all our staff and recognise that during what will, I suspect, turn out to be a very challenging winter period. When we move on to look at some of the hard outcome metrics, you may have well seen this. This is around non-COVID mortality during the pandemic. The graph on the left, the blue is all deaths, and the sort of the red undershaded is the deaths not involving COVID. So we see this very large spike in excess mortality in March into April, and then coming down by June. And you can see on the right different conditions, apart from the commoner conditions causing problems with things like dementia and Alzheimer's disease and cerebrovascular disease, ischemic heart disease, others. Respiratory disease, not quite so much. And you can see it here when we look at the PHE excess mortality tool. You can see on the left at the beginning of the pandemic surge, this increased mortality here. And then actually for respiratory conditions, we saw for a prolonged period of time, fewer deaths than expected. And I think this is really to do with shielding, but not necessarily shielding protecting patients from COVID, but protecting patients from other respiratory viruses. So when we talk to our patients now, actually, they often felt physically better during shielding because they weren't exacerbating. It's a really remarkable thing to see. Shielding had negative impact significantly in terms of psychological health and well-being, and also in terms of physical deconditioning because people weren't going out, they were getting less fit, so they often ended up feeling more breathless at the end of the shielding period. But physical distancing prevents respiratory pathogens from mixing and prevents acute exacerbations. So as we redesign our respiratory services, it isn't okay to say, actually, I'm going to do a COPD clinic and I'm going to bring 40 people up into the waiting room in winter and they're all going to sit next to each other. We're going to have to be smarter than that. We're going to have to accept that we need to try and minimise viral exposure moving forward. I've mentioned this already, but health inequalities were just shone a light on during COVID, and it was remarkable and chastening to see the differences. Mortality was significantly higher for those in the most deprived communities of England, and we could see that just within the microcosm of London. And again, mortality significantly higher in BAME groups compared to white ethnic groups. We were always committed to improving this, but this just within the long-term plan and respiratory medicine, but this just refocuses us and makes it really crystal clear the how far we have to go. And I think the other thing around health inequalities, I've talked a lot about digital already. We mustn't forget digital inequalities. It's all very well saying that we're going to use Attend Anywhere, but people have to have a laptop or a phone that works, the ability to use that, the access to that level of data or broadband. So it won't work for everyone. And we have to really remember digital inequalities as well as we're redesigning services. In terms of where we are for respiratory medicine, in terms of referrals, you can see a really significant decline in respiratory referrals at the end of March and into April. Now, this has started to come back up, and if you can look, we're up to about 3,000 referrals a week now, but that is not as high as the 4,000 to 5,000 that we had pre-COVID. So again, work to be done there around making sure that people go to primary and secondary care when they have symptoms of concern, and again, to make sure that everyone understands that the NHS is open for business. There was a very strong message to protect the NHS, which caused people to, in my opinion, stay at home, sometimes maybe when they shouldn't have done. And we have to encourage people back, and we have to encourage and make sure that we're open and to allow those referrals to occur. This is the scary graph for this winter from the Faculty of Medical Academies, looking at the reasonable worst case scenario for the number of COVID admissions and the number of hospital admissions. This should not occur because obviously the testing and the non-pharmacological interventions that are being brought in should impact on that and make these numbers lower. The NHS is very well prepared in terms of consumables, oxygen delivery, PPE, etc. And recovery study and other clinical trials mean that we understand far better how to treat people with COVID this time round. But we are still expecting a very challenging winter, and I know we all continue to prepare for that. So how have we done within NHS England to try and change our views and how we're going to do this? This is unless you're looking on a very big laptop or PC, you're not going to be able to read this, but this is to be able to remind me from our long-term plan respiratory work stream. So they've got the 5 on the left that we've talked about. We've transformed many of them. We've had to delay some, and we've brought others forward. So for instance, for now, we've delayed the community-acquired sequin because when people are presenting in large numbers with a viral pneumonia in A&E, it's not the right time to launch a community-acquired sequence. So we'll pause that, we'll bring that back. We've brought forward flexible learning because clearly a digital tool to help people with self-management is very well taken at this point in time. We are still trying to work around early and accurate diagnosis, and many of you will see that the Mike Richards report on with that. We're very lucky that Martin Allen is our GERF lead for respiratory medicine and has just recently been appointed as the National Specialty Advisor for Physiological Measurement. So Martin is working very clearly and closely with that team to make sure that pulmonary function tests are embedded within that programme. Pulmonary Rehab, those of you that have been on the National Respiratory drop-in calls and will know that this is an area that we're trying to stand up as best we can at the same time as looking at rehab for COVID survivors. At a time when we continue to need to be physically distant, so virtual rehab is a way forward, but doesn't work for everyone because initial clinical assessment is still key to knowing what is appropriate. Medicines optimization is still important, and certainly next year there will be a focus again on medicines optimization, and you will have seen Simon Stevens mentioning the sort of the zero carbon agenda quite rightly within the NHS moving forward, given the climate emergency that we are in and the impact of pollution on people with respiratory conditions. But we want to make it so that we can wrap it around improving care wherever possible, and as a very fortuitous consequence of improving that care, then we meet our carbon commitments. So something that we've brought forward that I'm incredibly pleased that we've done, and it's been gratifying to see how quickly this has developed, is respiratory clinical networks. So we always had an ambition within our long-term plan to deliver respiratory clinical networks. Now we were meant to think about that next year or the year after. Given all those pressures that I've talked about, so the next wave, dealing with COVID survivors, standing back up our services, and this winter's bed pressures, I was able to convince the people who hold the purse strings within the NHS ENI that we needed to do this earlier. So we've managed to set up with funding clinical respiratory networks across all the regions. Each region, interestingly, has a different model that's being adopted. And in the south, it's very much around a systems by default approach. So working with the ICSs with an overall clinical lead. We appointed to that post last week, and I'm very enthusiastic that will produce transformative change. We've had for a period of time clinical respiratory drop-ins where people across the country have been showing best practice. We're working really closely with the British Thoracic Society and the Respiratory Futures platform to make sure that it's available on there, and everything that we do in terms of a best case and best learning is available there. So if people want a plug-and-play solution for instance, COPD outpatients or end-of-life care or pulmonary rehab, whatever it can be, you can go to Respiratory Futures, you can find where an ICS or a PCN has already done this, and then use that rather than reinventing the wheel for your own locality. Really importantly, in terms of the network, it isn't for me and the central team to tell the networks how to deliver. There are some key metrics, and we've sort of mentioned those already, but I don't know the complexities of the localities, where the high risk areas are, where the high socioeconomic deprivation areas are, and also the plans and the people available. So again, it's a 10-year plan. So I'm very happy for each of the regions and the networks to deliver across that 10 years according to what they think is the most important priority, with the one caveat that the thing that I've stood up straight away is to make sure that we understand how, as clinical respiratory networks, we're going to deal with the next wave of COVID. So you can see, really importantly, again on this slide, is to remind me that it's very easy for me sitting in my ivory tower in Chelsea for people to think that this is a secondary care or a tertiary care thing. It really isn't. We fully recognise that the majority of respiratory care takes place in primary care. There should be a whole patient journey where we really optimise integrated care, and we bring care and expertise and testing closer to the patients rather than send them all to the secondary or tertiary care specialist clinics. Really, very importantly, multi-professional working, which I think we're pretty good at in respiratory medicine. We have MDTs across the piece, which we've been using for many years. And I think we understand with regards to workforce that we need to be upskilling individuals. And it isn't, and it won't be a medical model led by secondary and tertiary care consultants, because that really won't drive forward the transformative change that we need. It's certainly embedded with the improvements that GIRFT has suggested. And I've just been incredibly impressed with all of the regions, how quickly they've embraced this and how quickly they're moving forward. So just to finish off, within specialised respiratory services, again, we are making sure that all our services are stood back up. They're all open for business. We're keeping a very careful eye on the level of prescribing of the antifibrotics for interstitial lung disease and the biologics for severe asthma to make sure that those levels of prescribing are stable and aren't dropping off. We're working hard on lung function, and in combination with the British Thoracic Society, we published some clear lung function to make sure that people with interstitial lung disease have access to more pulmonary function tests when they need it, so that they can be prescribed NICE health technology approved antifibrotics. We're working on some things around complex home ventilation with regards to PPE and budgets and personalised health budgets. I've got a slide on triple therapy for CF in a minute, but we've seen a whole range of beneficial changes. So not just within severe asthma, but in CF. NHS England had purchased over 4,000 home spirometers for a big service evaluation of home spirometry and remote monitoring. And certainly at my trust for the adult service, they've moved to almost remote monitoring by default for people with cystic fibrosis, with a lot more ambulatory care moving forward. So these are transformative changes we always wanted to deliver on, but COVID has been the catalyst to allow us to do it at a far greater pace than we expected to be able to. So this is just a screenshot from the Tricafter announcement. So for people with the right genotype or the wrong genotype abnormalities in cystic fibrosis, they now have Tricafter available, triple therapy, which is really truly transforming in terms of impact, and that's being rolled out at pace. And I think virtually everyone should be on that drug by the end of this month if they're not already on that drug. And we're very, very hopeful that this will be transformative for many people, not everyone, but many people with cystic fibrosis moving forward. So the next 12 to 18 months, I need to update this slide because it says plan for the next surge, when it actually should really say deal with the next surge, because we're in it. Whilst trying to restore and continue as many of our poor services as we can over this challenging winter, whilst following up the previous wave and the future waves of COVID-19 survivors, whilst dealing with winter bread pressures, whilst changing our paradigms of care, pivoting our priorities within the long-term plan, and improving respiratory outcomes. So no pressure, not much to do. And clearly some of these things do on occasion keep me awake at night. And in an incredibly challenging time, but an incredibly exciting time as well, because I think for the first time in my career, respiratory medicine is really at the forefront of the agenda within the NHS. And this is an opportunity for us to transform outcomes for our patients and for everyone to understand the amazing things that respiratory teams across the country do, and to support them in a logical way moving forward. So to conclude and give a bit of time for questions, there is no doubt that respiratory medicine has been impacted by COVID-19 and will continue to be so. And I just, again, want to add my thanks to Joe at the beginning. Thank you to all of you for all the truly heroic things that have happened this year and will continue to happen over this winter. As a consequence of COVID, there's been such a paradigm shift and a pivot, focusing on remote monitoring, care closest to home, virtual consultations as default. And we cannot lose that, because I think when you talk to patients, that's what they want from us. And it doesn't always work and it isn't right for everyone, but as a default, particularly for follow-up, it is a very logical way forward. there is a considerable strain on diagnostic capacity. We are working on that. So the Mike Richards review around diagnostic hubs is very welcome and really recognises how important respiratory diagnostics, including sleep medicine, is within that. We're working through the early and accurate diagnosis workstream to get earlier diagnosis closer to patients at a PCN level. And the new models of care that we have will continue to be iterated. They're not the answer for everything, but they are a really, I think, positive step in the right direction. And I would encourage all of you to work with us, work with your HSN to demonstrate that these new models of care do improve patient outcomes and are clinically and cost effective. So I'm going to stop there, say thank you very much. I'm going to try and stop sharing my screen.
Thank you very much, Andy. That was great, and that interesting perspective about the positives and the negatives, and in our workplace balancing that up as well. So we've got some nice time for questions. We're going to start the next talk at 11, so we've got some time, and we'll, as I mentioned before, I'm just going to go a few things. If you're a later joiner, just remember to have your microphone muted and your video. If you want to ask a question, you can do that via the chat. We've got a couple that we're going to read out, and alternatively, you can raise your hand. Now that's not your physical hand, that's your little hand on the bar, which mine is at the bottom, some's at the top. So you can raise it, and if you can try and remember to lower it so you don't have what we call a legacy hand. So Julia, are you able to start asking some of the questions?
Absolutely, Joe. And Andy, thank you very much. A great overview. So first question on the chat from David Ross, also saying thank you very much. A very good talk. He raises the point of patients having shielded becoming very deconditioned, and that shielding is the antithesis of pulmonary rehab. So are there plans to promote a moderated form of shielding for our respiratory patients, for example, encouraging them to get out and go somewhere safe for mobilisation, such as a park or a country walk?
Yeah, so thanks, David. That's a great question, and we really have recognised that, along with the psychological impact, that's a real problem with shielding. So moving forward, the Chief Medical Officer's office is developing a personalised risk calculator, which will take into account age, comorbidities, BMI, ethnicity, to give everyone a more of a personalised risk, because we recognise there were some very blanket decisions made, and some people are relatively comfortable with their own risk. So I think a personalised risk calculator is quite a good way forward, so that if people want to take risks, they understand that associated with that, and if they don't have to, and we need to support them either way. But I think we also need to recognise that we can't just tell people to lock themselves away. And I think, given that we're now in a situation where there's a lot more non-pharmacological interventions in place in society as a baseline, we can be more sensible about what we tell people to do and what not to do. And our understanding of the virus is so much better, as you say. We know that if people are outside, the risk is a lot lower. So I think we should be really mindful next time round, if we do get to the point where we tell certain high-risk individuals to minimise social contact, to reinforce the benefits of exercise during that time period.
Thanks, Andy. And there's another question now from Emma Davies down in Sussex. So she's asking if there's a national coordination of how to restore lung function tests for patients not already known to secondary or tertiary care, and points out, as I think we know, that there's a big bottleneck with no apparent solution on the horizon.
Yeah, no, thanks, Emma. That's a great question. So I've talked about what the ARTB have done, which is great, and I recognise that works in secondary and tertiary, but not in primary care. So I've got a meeting with Nikki Kanani, who is the head of primary care for NHS England, tomorrow, to discuss how best to move this forward. Public Health England have also set up an AGP panel, because, as you'll be aware, there are lots of areas of confusion or lack of evidence about what constitutes a high-risk AGP and what doesn't. So this is very much on our agenda, and we're trying to move it forward as quickly as we can.
Okay. And James Calvert, who we'll be hearing from shortly, is asking Andy if you have know what the plans are for the NHS financial incentives, such as the best practice tariffs and the sequins.
Yeah, hi James, great question. So as many of us will know, that most trusts are still on a block contract at the moment, so we just get paid a certain amount of money irrespective of activity. So things like the sequins and the best practice tariffs aren't active at the moment. We are reinstating QOF. In fact, we have reinstated QOF. We have tried to stand back up some of our national audits. I suspect, James, that these will come back in for the next financial year. I don't think they're necessarily going to come in before then.
And the last question at the moment in the chat, Andy, is from Lisa Vincent-Smith, asking about designing an online exercise class for respiratory patients they can access if they're shielding.
So, I mean, listen, I think it's a great idea. I mean, we've talked a lot, Julia, on the national calls about virtual pulmonary rehab and virtual exercise classes. And there is always the concern, if people haven't been assessed face-to-face before, what's driving their breathlessness. We don't want to be over physiologically stressing individuals. So there's probably a middle ground. And again, the way that we've set up things up now with our clinical respiratory networks, with our national respiratory drop-in calls, with respiratory futures through the BTS. If anyone has these things, please tell us, because we will publicise them and make sure that they can be widely adopted at that pace.
And I think probably, if I may just come in further to that, of course the British Lung Foundation have readily accessible online videos under the title Stay Active, Stay Well, so people can access those at any time, and there are others around, as Andy says. Another question has just come in, Andy, from General Practice Summer Dune. What a great name. We'd all like to be there, I have to say. It sounds lovely. So saying that our QOF is about not doing any respiratory reviews until they are deemed clinically essential. Is this being run?
So the short answer is no. During the height of the pandemic, we did issue some guidance about annual reviews, saying that you should continue to do those for frequent exacerbators and high risk airways disease patients, but you could pause others, but keep a list and reactivate them. That's been stood down now. So we should be doing annual reviews. And for all the reasons I was talking about around winter pressures, it's really important that we make sure we've caught up with annual reviews wherever possible.
Right, I've got no more questions in chat, Joe.
Well, you can't miss Lisa out, surely. Lisa Vincent-Smith over Medway has asked, oh no, we have asked that one,
yes,
haven't we? Sorry about that.
No, I wouldn't have missed Lisa. No.
Oh dear, how embarrassing. So, but
you missed me. It's all right. I don't feel.
You nearly got to ask twice, Lisa. So Andy, maybe there's a couple of things actually. Could you say a little bit more about the flexible learning? Because I think that's really interesting, because it was very successful, has been successful in diabetes care. About maybe the timescale when we might expect that, and if you have any ideas what format it might take.
Yeah, Joe, so great question. I think diabetes was a driver for us, because we've seen how effective it has been there. So the idea about flexible learning is when people get a diagnosis, it's a lot to take in, actually. And often if you're told you have COPD, you may not really remember the rest of that consultation. And actually, there's a lot to think about. There's about lifestyle modifications, new medicines, what this diagnosis means for me, changes in diet. You might want to look at comorbidities, et cetera, et cetera. So the concept that we could build a flexible learning platform that patients can either access when they want to, or healthcare professionals can go through with patients, is really driving that. And we're working very closely with the BLF and Asthma UK to make sure we have appropriate patient-specific input. And in fact, I think we've got one of our workshops on that next week. So at the moment, there's some very rough drafts, and they're being workshopped with patients primarily, rather than with healthcare providers, but also with healthcare providers. And then we'd be looking to start to pilot those next year in 2021. And that's one of our priorities. We've absolutely moved forward. That was sort of maybe one of our 3-4 year time priorities, but we've moved it right forward because we recognise it could be of incredible value during the pandemic.
So perhaps a little wait for that to come through.
Yes, trust me, that's quick from a central point of view, but yeah.
Okay, and then I guess another thing too, you did explain that, but maybe people aren't familiar with some of the terms that the new clinical networks are not the same footprint as the academic health and science, what we call to date networks. and you mentioned systems, and maybe people might not know what those systems are. I don't know if you're able to. We're keen to
Yes,
kind of work in that system, and I hope we can complement that setup. I don't know if you're able to share who's going to be our lead. You might not have that at the tip of your tongue, or whether Vanessa wants to come in and say anything about that, because I think that'd be quite helpful for people to know.
Hi, it's Vanessa here. Can you hear me?
That's great. Yeah, thanks very much, Vanessa.
Let me just put my headphones on so it's clearer.
And maybe if you could, I've forgotten your exact title, maybe you could remind me.
Yeah. Hello, Vanessa Arnell-Cullen. I'm Head of Clinical Programmes for NHS England and Improvement for the Clinical Delivery and Networks, and I lead on respiratory, cardiac and diabetes. The respiratories is an emerging network, and what we've done is we've been given the opportunity to start fresh and work with our 6 systems across the whole of the South East. So you'll be aware of Kent and Medway, but we've got Sussex, we've got Surrey Heartlands, and there's more to the west. I'm not going to go through all that, but essentially these are going to be systems that work across all organisations and boundaries and commissioning for one common vision. How great is this going to be? It's going to be great. And to be fair, all of the systems across the whole of the South East are in different positions. So what we've decided to do is there was money allocated nationally to coordinate and optimise our efforts rather than working in individual silos, and to concentrate our efforts rather than and to build on those. Sometimes the right decision is not always the most popular and more affordable decision. So that was decided. A group of us met with all the STP leads, and what they wanted to do is organise their respiratory programmes themselves to allow to focus on their individual needs and their population, and also with a focus on the health inequalities and areas of deprivation, and wrap around the existing commissioning and services that they had. But what they wanted is a coordinated approach. So we have got, as Andy mentioned, a respiratory lead who's Dr. Richard Russell, a notification's coming out, who will coordinate between us all how best we can share, we can learn. I think that's probably enough. I could speak for an hour, but we've got other things to discuss. Does that help, Joe? Any questions?
Yeah, that's really helpful, Vanessa, and it's really great to hear about Richard again, someone we've worked with previously. So that's great to hear, and we look forward to putting our efforts together. Yeah, great. So there is another question there from Barbara Rayner, who's in the integrated care system in Sussex. Who's asking, will there be a framework delivery for the respiratory networks, or is it be left to individual systems to understand their priorities? I think you did mention that, Andy, but maybe you could reply again.
Yeah, no, of course, Joe, and that's an important question. So clearly, centrally, we are committing significant financial cost to the networks, and we're planning to, wherever possible, support them for multiple years going forward. There's no point in doing this for 18 months. It won't deliver what we need to do. So we do have to have some metrics to hold people to account to. But as I said earlier, I really do not want this to be a central diktat. It won't work that way. Each of the regions, and as Vanessa was saying, the leaders within the regions understand the priorities, understand the health inequalities, understand their people and their plants and what they can deliver. So they will be as, not generic, but they will be as loose as they can be to give me the confidence that it's working, but at the same time allow each of the regions to do what they need to do in the order that they need to do it in.
So I hope that's answered your question, Barbara. So we can't see any other, Sue says thank you, so there we are. I can't see any other questions coming in, so it just remains for me to thank you very, very much, Andy. That was a great overview. It's, like you say, exciting, challenging. There's all that SWOT things, opportunities, threats, but I'm sure together we'll all be as best prepared we can be. So what we're going to do is we're just going to go back to our housekeeping slide. for 3 minutes, and at 11 o'clock on the dot, we'll start off again. So thanks everyone, and thanks for your contributions.